My name is Ryan McGrath. The presentation today will focus primarily on mobility and functional impairment with an emphasis on hand grip strength. Just a little bit about myself. As kind of mentioned previously, I'm an assistant professor in the Department of Health, Nutrition, and Exercise Sciences at North Dakota State University. I'm no stranger to North Dakota. I actually received my master's degree from the University of North Dakota, so I always enjoy kind of working with and collaborating with my colleagues in Grand Forks. I'm also affiliate faculty at the Center for Large Data Research and Data Sharing and Rehabilitation at the University of Texas Medical Branch. Just some of the research that I do have going results or comes from the epidemiology of aging, a variety of topics related to physical activity and health across the lifespan, but particularly with an emphasis on maybe middle age and older adults, and just kind of looking at how we can improve how we assess a number of different patients or a number of different individuals with instrumentation or just non-instrumentation. So some of the things that I do have going myself. Now, I hope that you are able to get a few things from this presentation today. Some of the primary presentation objectives include examining how muscle strength is assessed in clinical settings, evaluating why low hand grip strength is overall bad for health, and determine possible limitations for hand grip strength and how some of these limitations could help to be overcome. So during the aging process, older adults may experience a variety of body composition changes or just changes in their body system pathways overall. Some of these changes in the body systems may lead to reduced muscle mass and strength. Oftentimes we recommend that older adults, not just older adults, but individuals throughout the life course, engage in a series of muscle strengthening activities that may include maybe good health behaviors such as nutrition, such as physical activity participation. And this diagram on the upper right corner, that comes from the World Health Organization, just shows maybe an example of an individual who engaged in healthy behaviors or muscle strengthening activities, maybe earlier in life, and then has continued those activities into adult life and older adulthood. And you'll notice that they were able to maintain or preserve their muscle mass or strength relative to an individual who maybe did not engage in a healthy lifestyle, including a good diet or maybe physical activity participation. And as they began to age, their muscle mass and strength was not as robust, maybe relative to the person that was engaging in healthy behaviors. And as a result, they maybe are at a greater risk for functional disabilities, such as basic self-care. Just looking at maybe some imaging that comes from maybe muscle mass and strength, an individual that's engaging in healthy behaviors or muscle strengthening activities, maybe, for example, a 70-year-old triathlete on the lower right corner diagram. Very robust muscle mass, very good muscle quality, nice and dense muscle structure, good bone mineral density as well. Maybe relative to the individual that was sedentary throughout their life course, you'll notice that the bone mineral density maybe isn't quite as pronounced. You have a lot of intramuscular fat and a lot of fat surrounding the muscle tissue. And as a result, this may lead to an increased risk for age-related morbidity and mobility impairments. So it can be really difficult, however, to assess muscle strength in clinical settings. With particularly older patients, we can't ask maybe older individuals to engage in assessments that would be very strenuous. There can be some limitations. So, traditional gym-based memberships that maybe we oftentimes think of when we think of muscle strength are by no means applicable in clinical and even research settings. And instead, we can measure muscle strength or muscle function with hand grip dynamometers. This is an example of a needle-gauged hydraulic hand grip dynamometer. They cost maybe about $35 to $40. So they're economically feasible, and this is oftentimes what's used in clinical practice for evaluating not just muscle strength, but overall muscle function. So measures of hand grip strength or maximal hand grip strength specifically are regarded as a convenient assessment of overall strength capacity and reliable measure of muscle function. There's a number of different protocols that do exist for examining hand grip strength, but generally you're going to want at least 2 measurements on each hand, and you ask individuals to squeeze the dynamometer after fitting it to their hand size with maximal effort, and then the highest value ascertained from those trials would be the value that you include maybe in their decision tree or for the analyses for overall muscle strength. So very feasible, very inexpensive, and is oftentimes used as a result of those characteristics. Now, however, we have to consider where does maybe low muscle strength or low muscle function factor into the disabling process, because when we're talking about hand grip strength, we're usually talking a little bit about maybe sarcopenia or dynapenia, or maybe factors related to sarcopenia such as falls. So a number of different mobility and morbidity factors when considering the disabling process. But hand grip strength first, is measured as a measure of muscle function, and this is maybe the onset of the disabling cascade. And it's important to maybe consider maybe the onset of the disabling cascade, because we can help to identify then individuals that would be at risk for progressing within the disabling process, but also identify individuals that would be able to intervene earlier, and we can prescribe maybe muscle strengthening activities or other healthy lifestyle behaviors to help preserve muscle strength overall, and maybe even reverse in some cases, and decelerate the disabling process. Aside from muscle strength, just another example of a measure of muscle function that can be conducted in clinical settings is knee extension power. Knee extension power, although is a good measure of lower body strength, it requires a very expensive piece of equipment. The procedure overall takes several minutes, and maybe even in some cases an hour. And overall, just individuals as a whole may not be able to complete a knee extension power test relative to a hand grip strength assessment. As we progress, we may be in the disabling cascade. Measures of physical performance that you may identify and be familiar with yourself may include gait speed, chair stands, the short physical performance battery or tug tests. And all of these things are predictive of maybe a limitation in activities of daily living, or maybe just a diagnosis of sarcopenia. So you can kind of identify maybe how we assess the disabling process and what types of measurements are appropriate for each stage of the disabling cascade. We also have to consider maybe the feasibility and validity of each of these measurements. This diagram here does a good job, I think, of kind of outlining the balance between each of the measurements. Now, there could be some criticisms linked to measuring hand grip strength, and we'll get to those in a moment, but some of the alternatives that we may want to consider would be imaging, which can be expensive, exercise testing, which can be timely and not generalizable to a lot of individuals. Dynamic assessments might be really limited to individuals that already have a disability, and that leaves us with maybe dynamometry at multiple sites on the body and dynamometry at a single site of the body, such as hand grip strength. Some have suggested that maybe we consider both hand grip strength as a measure of upper body strength and lower extension power, or knee extension power as a measure of lower body strength. But hand grip strength and lower extremity power tend to be really related, and the overall feasibility isn't low, or the overall amount of information that we gain doesn't necessarily outweigh the feasibility loss with regard to measuring hand grip strength on a single part of the body. So it's generally thought of as being hand grip strength being a good proxy assessment of overall strength, regardless of the overall measures, considering its feasibility. So hand grip strength is oftentimes measured in kilograms. And as we take the highest measurement from the grip force task, we can use that information to do a variety of different things, such as determining categorical weakness. There's a variety of maybe thresholds or cut points that do exist for determining weakness. This example here tends to be sex specific. So for individuals that have a hand grip strength of less than 26 kilograms may be considered weak if they're male. And for females, a hand grip strength less than 16 kilograms may also indicate categorical weakness. Because body composition and body size may help to factor into performance in hand grip strength measurements and just overall strength in general, we can also normalize the actual raw measurement by taking the raw measurement and dividing it by an individual's body weight, or dividing it by the individual's body mass index. And that might be able to provide more insights into what their actual normalized strength is to their body mass or body mass index. And then likewise, we've looked at categorical weakness. Maybe we would want to consider examining weakness or hand grip strength in general to their peers. So looking at percentiles and looking if a hand grip strength for an individual's sex or their age would lie on maybe the 70th percentile or the 80th percentile. So all of this information does exist within the scientific literature. We can also use measurements of hand grip strength in decision algorithms. These are two examples of decision algorithms. The algorithm that you see on the left would be an algorithm that includes a measurement of hand grip strength and determination of sarcopenia. The other algorithm that's on the right is another algorithm that would utilize hand grip strength that would help in the decision algorithm for determining diapenia. Oftentimes muscle mass and strength, while they are related, it's recommended that we maybe evaluate muscle mass and strength separately overall. But nevertheless, hand grip strength is an important characteristic in determining low muscle mass and strength. Thinking about frailty, a number of different frailty indexes do exist, and frailty is a very important, physiological pathway that we may want to consider for an individual's ability to maybe overcome chronic or acute stressors. And this is just the most simple, maybe, frailty criteria. This is the Freed frailty criteria that takes into account 5 different characteristics, such as unintentional weight loss, self-reported exhaustion, walking speed, which is oftentimes used with gait speed, physical activity participation. Then we also see, in this case, weakness as determined by hand grip strength. And this frailty criteria does represent that weakness is the most prevalent characteristic that is often identified within the frailty criteria. And again, it represents the onset of other criteria becoming deficient. So low hand grip strength or weakness overall is also linked to a lot of really bad health complications. This is some work that has come out of my lab, for example, wherein we've determined that low hand grip strength is associated with, in males, 22% increased risk for diabetes, and in females, a 24% increased risk for diabetes. Likewise, when considering hand grip strength and the associations with chronic heart failure or heart disease in general, weakness was associated with a 35% increased risk for chronic heart failure. Also, getting away from maybe some metabolic factors and maybe looking at hand grip strength as a neurocomplex, we have found that low hand grip strength is associated with dementia overall. In the examples that we're determining here, low hand grip strength was associated with a 16% increase in mild cognitive impairment, a 6% increase in severe cognitive impairment, and then a 14% increased risk for the progression, going from no impairment to having a mild impairment to having a severe impairment. So all domains of cognitive functioning or the severity of cognitive functioning would have a linkage with low hand grip strength. Functional disability, low hand grip strength or weakness tends to be a hallmark characteristic for functional disability in instrumental activities of daily living or activities of daily living limitations. There's a lot of different ways. Functional disability has a lot of flexibility in how it's defined. And overall, functional disability is a binary variable in which an individual reports having difficulty or an inability in completing a basic self-care task, for example, if you're examining activities of daily living. So not only is low hand grip strength associated with that umbrella measure of functional disability, but it's also associated with each individual basic self-care task. So it's a very strong predictor of functional disability. And what you see is colorful diagram. It's called a Stinky Bar Chart. What you're seeing here is individuals that have a number of different limitations. So purple would be an individual that has identified as having one activity of daily living limitation. The next color, the blue color, would be 2 activities of daily living limitations. So the more activities of daily living limitations you have, the more severe the basic self-care disability might be. And you'll notice that these functional limitations are very fluid. So an individual can progress in their functional disability, and also an individual can recover in their functional disability. And maybe hand grip strength would be an opportunity to identify an individual that maybe would be at risk for future accumulations and basic self-care limitations, or an individual that maybe can recover nevertheless. So it's important to consider these things, and important for how we can get individuals to regain their function back. Low hand grip strength might also be associated with osteoporosis or factors related to the bone. We talk a lot about muscle, but muscle and bone and strength of these characteristics are highly related. So it's not surprising to see that low hand grip strength or weakness overall would be associated with osteoporosis. And then just overall, early all-cause mortality. This study, we implemented a robust statistical analysis that mimicked a randomized controlled trial. And after matching individuals on a lot of different characteristics that would be predictive of early all-cause mortality. And the only thing that is different between these individuals is their weakness status. Are they weak or are they not weak? And individuals that were identified as being weak relative to their not weak pairs are at a 40% greater risk for premature death. So overall, I think that series of slides kind of demonstrated not only the importance of maybe hand grip strength, but why it might be bad for health. But then we get into the implications as to, if we measure hand grip strength, how are we going to be able to communicate what weakness is a risk factor for to our patients? Because It could be associated with a lot of different things. We have things ranging from maybe metabolic level, such as diabetes, all the way down to maybe more of a neuro level, such as dementia, and just overall early all-cause mortality. So it can be a little bit complicated explaining to individuals why weakness is important and what it might be a risk factor for, because it can be a risk factor for a lot of different things. How often are these hand grip dynamometers used in clinical settings? They can be used frequently. The table that you see here comes from a European group, and they did a small survey sample of individuals that may measure muscle mass, muscle strength, and physical performance within their clinical practice. And you'll notice maybe that of the individuals that do engage in these types of measurements, that 66.4% of them measure hand grip strength. It doesn't necessarily take into account all healthcare providers or individuals that are working with patients in a clinical setting, but of the individuals that do assess muscle mass, strength, and physical performance, 66% of them do take into account hand grip strength. And maybe it's interesting to maybe compare maybe the gait speed measure that is advised at 63.3%. You see timed up and go that is frequently used. So an interesting table nonetheless to maybe see what other clinicians are utilizing in their clinical practice. So maybe to help overcome some of these limitations, there have been some things that we are doing and that some of my colleagues globally are also doing. This may take into account, we think about only ascertaining or measuring the highest amount of grip force generated, and that's the only measurement that we consider. Well, what about strength on both hands? And then we consider maybe hand grip strength asymmetry, so we can maybe help to identify maybe some strength imbalances that are occurring on one side or another. This may help to predict maybe, for example, falls. Clinically meaningful differences within measures. So an individual that maybe has a very strongly performing measurement on their first hand grip strength trial, maybe has a very poor performing measure on their subsequent hand grip strength trial, and would that be indicative of maybe something going on within their neuromuscular functioning? You'll also notice in the example that I showed you before, I showed you a hydraulic dynamometer that uses a needle gauge, maybe similar to how I would measure tire pressure on my car, for example. And those technologies are getting to be a little bit outdated now. So new technologies allow us to maybe store hand grip strength within a computer, so we don't have to worry about maybe poor quality control or purity of data with our patients. These technologies also allow us to view maybe grip force in real time for a duration of a gripping task. So we can not just measure hand grip strength, but we also may want to consider, for example, our explosiveness or our fatigability, such as our ability to squeeze the dynamometer with maximum effort for as long as possible. So we might be able to implement other aspects of muscle function within the new technologies that would help to, I think, us better operationalize muscle function as a whole and maybe improve the predictive utility of the test overall. So then what about physical activity as it pertains to hand grip strength? What about nutrition as it pertains to hand grip strength? And a lot of the literature does suggest of interventions that have sought to make changes in muscle strength and have used hand grip strength as their proxy assessment of strength capacity. Marginal differences pre and post, and that seems to suggest that maybe hand grip strength, while it is a robust predictor of muscle function and maybe poor health problems, it doesn't necessarily identify changes in strength that might actually be occurring, which is why I think it might be important for us to continue to investigate how we can improve hand grip strength or just overall measurements of muscle function in general, so we can better determine if the interventions that we're prescribing patients are actually effective. And this might have use also in maybe other clinical settings, such as hospitalizations, or maybe an individual that has sustained a fall, so we can maybe determine if their functional status is putting their life in jeopardy, or if an individual is able to better recover from a hospitalization, and monitoring maybe their muscle function. Something that, as I think, emerged is important. So overall, just as a summary assessment, measures of hand grip strength are a convenient measure of muscle function and overall strength capacity as a whole. And given that it's utilized in so many different things and is predictive of a lot of poor health outcomes, hand grip strength is regarded as a powerful biomarker of aging. But nonetheless, it does have its limitations and opportunities for improvement because it is somewhat incomplete, such that we're only measuring muscle strength overall. Nonetheless, however, it is widely regarded as being recommended for use in routine geriatric health assessments. And that's it. I have my email listed here. If we have any inquiries, I can help to maybe answer those inquiries for you now. If you don't have a question now, you can also send an email, which is listed here. And then I also have some case study slides thereafter. So thank you for your time.
Wonderful. Thank you so much. Does anybody have any questions for Dr. McGrath? Feel free to either pop them into the chat or unmute yourself.
Yeah.
Okay, so we do have a question here. Why do you think there's been low clinical acceptance of grip strength?
That's a really good question that I'm not sure if I have a specific answer to. I've also done research on dementia screenings, and a lot of the research that I found has likewise identified that there isn't a lot of dementia screening that is occurring within like routine purposes. It just maybe takes more time. It maybe takes a little bit more of an economic investment to buy a hand grip dynamometer and train individuals as to how to use it, even though it's quite simple and quite inexpensive nonetheless. But sometimes we just have to acknowledge maybe what are we doing in clinical practice and how can we improve our clinical practice measurements to help improve our patients. And while I don't necessarily know specifically why measures of hand grip strength aren't being used in clinical practice, I would encourage healthcare providers to maybe reevaluate what is being assessed and consider hand grip strength in those assessments.
Thank you. We have two other questions that have come through. I'm going to kind of do them out of order because they, one of them has to do with a case, so that can kind of segue in. But how do we encourage PCP to use grip strength? Are the meters available in most clinics? Do they need to refer to PT or OT?
I would say that we can refer individuals that maybe are identified as having weakness or low hand grip strength to physical therapy or occupational therapy. But I would also suggest that maybe, low hand grip strength is a single marker. Although it's a powerful marker, it is nonetheless just one thing that we may want to consider with regard to maybe referring them to physical therapy or referring them to occupational therapy. I would say that if you do have an individual that is identified as being weak, I would strongly encourage you to consider maybe just prescribing muscle strengthening activities to those individuals. And if that isn't available, then considering maybe physical or occupational therapy. But likewise, again, I'm not aware of any such case wherein healthcare providers that utilize measures of hand grip strength and identify patients as being weak would automatically refer physical and occupational therapy.
Okay, thank you. Couple other questions. Thank you everybody for the questions. And I do want to point out that Kara did put a link in the chat with some studies that she said she likes to share with others. Is there any evidence to your knowledge that physical activity prescriptions for older adults can change grip strength? And if so, by how much?
Yeah, outstanding question once again. A lot of really good questions here, by the way. Some of the evidence that I have seen, I've seen what we call in the literature systematic reviews and meta-analyses, which tend to be really comprehensive studies that include the results of a lot of multiple studies that are in smaller scale. And what I've seen as it pertains to those results is that prescribing or interventions, as we call them, muscle strengthening activities, such as maybe physical activity participation, really has marginal influences on hand grip strength after an intervention is completed. And we really don't know why, because we know that for the most part, and eating healthy foods, maybe physical activity participation, sleeping habits are conducive to muscle mass gains and muscle strength gains. But we nonetheless don't see those oftentimes identified within hand grip strength. And I think that that's kind of where we're at, maybe as clinicians or maybe where we're at with scientists for how do we utilize this device and how can we maybe circumvent this problem to better measure muscle strength, because it would appear that maybe when considering something before and something after to improve muscle strength, a measurement of hand grip strength is not a good tool there. So I think that that's kind of what we're working on now, is how we can improve this tool so we can help to determine the efficacy of like these interventions or these exercise prescriptions to make sure that they're working and working well. So while I think hand grip strength is a good measurement for use in clinical settings for identifying weakness and maybe poor health problems, I would not recommend it for use to help determine before and after change with regard to muscle strengthening activities.
And this one, there's two here from Nancy, so I'll kind of put them together. Would it be helpful to get baselines on an annual exam? And how do we educate older adults on these evaluations and this information?
Yeah, another really good point, outstanding point. I would recommend, you saw on my last slide that measures of hand grip strength are generally recommended for routine clinical practice and geriatric assessments. And I would encourage you to maybe consider this for your practice as well. So maybe having a baseline measurement and observing those measurements over time, so you can determine if there's like a very large drop in hand grip strength that would help to represent maybe something wrong that's going on within the muscular system. So then maybe we can provide that opportunity to intervene, or maybe provide that opportunity for referral to physical or occupational therapy. And the point about how do we explain why this is important, I think that we can explain why this is important, why weakness is important for avoiding it for our older patients, because we talk then a little bit about the health problems that are associated with weakness. Maybe we consider also, weakness is kind of oftentimes regarded as like a shell or an armor of sort, and the weaker your armor might be, the more vulnerable you might be to stressors. But the challenges that I think we face right now is what exactly is weakness and low hand grip strength a risk factor for, because as you've seen in my slides, it's associated with diabetes, it's associated with osteoporosis, it's associated with dementia, and all of these outcomes are very, very different. So I think that as we progress, we need to do a better job of not only identifying, what types of areas of muscle function that we can also maybe measure that would help to be more predictive of each of these outcomes, but similarly, maybe provide like specificity for diagnosis moving forward.
Okay, thank you. And you did say you had some case study slides, correct?
Correct.
Okay, good, because we do have a question. Do you have any cases to share when you have used hand grip strength? So if you want to go ahead and do that, that would be wonderful.
Sure, I do have two cases. The first case I think was touched on with one of the questions that we had actually, and I'd be really interested to see you as clinicians or healthcare providers, what your feelings are about this. But you saw in maybe one of my slides that some research shown in the presentation suggested that many healthcare providers do not utilize clinical assessments of physical performance, such as hand grip strength or gait speed. Do you utilize assessments of physical performance, and why or why not? In my experience, I don't oftentimes see measures of hand grip strength used. I know here in Fargo at the South Point Clinic, there's been some discussion. I think I've absolutely observed gait speed measurements taking place, but are we utilizing this? Are we not utilizing this enough? Might it be important? So not only is this a case example from something that I've observed, but it's a nice opportunity maybe for you to share why or why not you might be utilizing these measurements.
Absolutely. Does anybody have any anything they'd like to share?
I can chime in. We, of course, do use all these different assessments in our practice because we want to gauge when we're first starting working with our clients where they're at, and then look at how they progress over time. So we do them on a current, recheck often throughout the time. So
thank you.
Might there be some insights as to maybe why these aren't being used? I think the response that we saw would be a very good justification for assessing strength and physical performance in the clinical setting, but why not? Why wouldn't we want to do these things? And I think that that's kind of where the question we had before alluded to. That's kind of the case example that I'm mentioning here. Why might not these measures be being used?
We're not seeing anything come through the chat yet. I don't know if we want to give it a minute or.
Yeah, it can be anecdotal. I mean, I know I gave my example for, maybe there's a cost and training curve that needs to take place. Maybe it's not valued in clinical settings. You know, any answer is really acceptable, but it might be interesting to understand why.
Well, I can chime in. So I've been an occupational therapist for 20 plus years, and I've taught occupational therapy students for 8 years, and also an academic fieldwork coordinator. So I send students out in the field, and this is going to be a little negative response, but I just see that clinicians just sometimes don't do it. I mean, they just don't see the need and don't do it. I mean, some are lazy and just do the same thing over and over. In our fieldwork students' biggest concern when they went out to fieldwork practices were that all they saw was the same thing every day from when they were out on fieldwork. Like they saw a TheraBand, they saw just their same routine rote things and minimal assessments. So I don't know, sometimes these students go out and then they get in the place and they pick up the habits and then it just continues. So we really need to be showcasing the importance of why we need these assessments, why we need to do, you know, I'm obviously a big proponent of occupation-based, client-centered care, but it's huge. Another thing, just from an example of a client this morning, you know, we need to do a better job of not just working with the one client, but their family members and caregivers too. Like a client I see, he has Parkinson's, and she loves that, you know, we come in and work with him, but she won't let him do anything during the day. So for instance, today was the first time he's made his own toast. He washed dishes, and he's like, I want to do this, but she won't let me. So just having that discussion with caregivers too for our older adult clients that are now stuck in their homes more than ever on the importance of functional activities. If we're not using our hands, if we're not moving our bodies, they're not going to get stronger and they're not going to get better. So yeah, just a few little points or discussion that I see anyways.
Yeah, that's great commentary. Thank you for that commentary. You know, and you make a lot of good points. You know, when we have maybe some of our physicians in training or therapists in training go out and observe individuals, interact with individuals in the field, you know, it's not uncommon for the individuals who might be training these trainees to be, you know, introducing them to maybe what they're working with. And I mean, I'm in academia, for example, you know, it's not uncommon for maybe professors to be recycling lectures and recycling materials, you know, over the course. And it's not intentional necessarily, but we just kind of get in a habit. And maybe it might be important for us to maybe kind of reevaluate what we're doing in the clinical practice and take into consideration some maybe other assessments, as you alluded to. So a lot of really good points there.
Okay, and we do have a couple of comments that have come in through the chat. Carla says we used to do grip strength when we did geriatric assessments with an interprofessional team. However, when people are coming in for an annual assessment in the clinic, it seems much of this isn't happening. So many things to look at, especially with medication review, etc.
Yeah, again, and clinicians might be, you're asked to do a lot and maybe asked to consider a lot of different types of things. And, you know, there's a lot of things that you can do maybe in a routine geriatric health assessment. So, I mean, it's important to maybe not only evaluate hand grip strength, but I'm sure that there's a lot of other things that could be considered. And at what point do you stop? You know, and that's a difficult question to answer, I think.
Mm-hmm. And Dr. Jurevich commented, there's evidence that upper extremity exercises alone are beneficial for COPD and CHF patients. Can grip strength guide this intervention?
I think it would be worth looking at, given that the evidence of physical activity participation as an intervention pre and post, we've seen kind of like negligible or marginal changes as it pertains to hand grip strength. I would maybe be a little bit cautious about maybe having that be a primary measurement within those types of activities with those criteria of patients, for example. And I would encourage, I think, given the limitations that we've seen in the literature of utilizing hand grip strength for muscle strengthening interventions pre-post, I would also maybe ask you to consider some alternative measurements to maybe measuring muscle strength or muscle function aside from hand grip strength. And that might include maybe some of these new performance measurements that we're considering with digital hand grip dynamometers and accelerometers. This may also include measurements of physical performance, such as gait speed or tug speed. So there's a lot of different ways that maybe we can assess pre-post performance, but I wouldn't put all my eggs in one basket as that pertains to hand grip strength, for example.
Okay.
Do have one more case example. We can move on if you'd like.
Yeah, great.
So in this is maybe a little bit more of an applicable case example, just maybe of something that I've seen in the literature, but an older patient without an age-related disability or morbidity, such as inactivities of daily living disability or sarcopenia, respectively, was identified as having low hand grip strength, but not poor physical functioning. So you maybe saw on one of my earlier slides kind of the categories of the disabling cascade. And oftentimes it starts with low muscle function. The progression of the disabling cascade oftentimes specifically starts with low muscle function as measured by hand grip strength, and then progresses into low physical performance, such as gait speed, timed up and go, and then thereafter progresses into age-related disability and morbidity. So what would you recommend for this patient that maybe was identified as having low strength or poor muscle function, but not has yet accelerated through the disabling cascade?
We have a comment here from Dr. Jervich, high protein diet.
Yeah, absolutely. There has been some research that suggests that not only the quantity of protein that we consume, but what the timing, the spacing of the protein that we're consuming. So having multiple meals throughout the day might be representative of maybe limiting accelerations within the disabling cascade or preventing functional disability. So high protein diet, maybe working with a dietitian to consider other macro and micronutrients might be very important and a good first step. So that might be a good first referral for an opportunity to intervene. Now, one of the benefits of measuring hand grip strength, I will say, is because it represents the early parts of the disabling process, we have opportunities to intervene right away. So an individual that may, for example, have slow gait speed, they're a little bit deeper into the disabling process. So implementing interventions and seeing efficacy within our interventions might be a little bit more challenging. So low hand grip strength, earlier in the process, prescribe protein, prescribe maybe a referral to a dietitian, outstanding idea.
Okay. Dr. Jervich also does say 8,000 steps daily. He said his mic isn't working on his computer, so I'm kind of I'm his mouthpiece right now. Does anybody else have any comments, anything they'd like to share? Please feel free again to unmute or go ahead and put them in the chat box.
Obviously, I'm biased, but this client would be a great client for a referral. We see clients for an OT or PT referral. We see clients in their home. We bring the outpatient clinic to them, so we're not home health therapy, but to get into their home and see how they function in the home, because this client, might not have poor physical functioning with a gait speed, but when we can go and see how they actually function in their home, getting from one spot to the other, looking at, their functional transfers, what they can and cannot do, there might be some things that we can recommend to keep them safer, plus get them on a functional home program where they are doing things throughout the day that keeps them higher functioning. It doesn't have to be a long-term stay, but I just feel that if we were in these homes and could actually see what's going on, we can really make a difference, because how they present in the clinic versus how they are in the home is often different.
Oh, absolutely. Yeah, the environmental characteristics, do play a strong factor. We also maybe want to consider fall risk assessments, for example, and then maybe evaluating at-home hazards to maybe, reduce that fall risk would be a very nice opportunity, as you mentioned, and, also maybe considering some measurements that we could implement at home. I know that there maybe are some phone apps that might be, very useful for maybe monitoring patients, and this may be something that we maybe want to consider as well. So you make a really good point there, and a really outstanding opportunity for referral.
Okay, so we have a question. Are these low grip strength with preserved function more common with increasing age?
Can you just say that one more time, please?
Sure, yep. Are these low grip strength with preserved function more common with increasing age?
I would say overall, no. Age is a powerful risk factor for, I think, diminished functional performance and just low hand grip strength overall. I think that when we start thinking about aging and the aging process in general, and maybe as we have like the young old, the middle old, and the old, and we start to categorize older adults based on their age, the age-related factors, you're going to see, I think, just changes in physical performance, changes in muscle function, and reduced hand grip strength, for example, over time. So I think when we talk about maybe over longitudinally opportunities for intervening, I think that an important word might be to preserve strength or to maintain strength. There might be opportunities to actually improve in some cases, but we're looking to really maintain preservation in these cases. So age is a powerful predictor of these declines, and there's unfortunately not a lot we can do to stop age.
Okay, does anybody have any other questions, comments? Please feel free. Okay, so we do have another one. Any experience with grip strength and cervical spinal stenosis patients?
Oh, I personally don't have any experience there. I know that a lot of my colleagues do, utilize maybe hand grip strength in the cases that you're alluding to, and maybe even, I think in some cases, utilizing like shock type technologies to kind of stimulate the neural system to help differentiate the neural contribution relative to the muscular contribution of muscle strength and physical performance and just overall muscle function in general. It's really, the neural contribution to overall strength is very important. Neural drive does it, there's diminished neural drive when considering low hand grip strength. And I think that the neural systems and how that would interact with the performance is a strong predictor, I think, of dementia. And I think that that's what we've seen in the literature is that, we maybe think of muscle strength as something that's occurring at the muscle system level, but it's the neural factors is also just incredibly important to consider, and how maybe diminished neural system functioning may be a factor for some of these neural complications and neural outcomes such as dementia. But in terms of like spine and spinal cord, I don't myself have a lot of experience interacting with those types of patients.
Okay, thank you. And Dr. Jurevich is wondering if you'd like to comment on future or different grip strength tests, such as like power and fatigue and things like that.
Yeah, I mean, and that's kind of talking a little bit about the opportunities that we can overcome some of the limitations. Now, maximal strength, outstanding, robust. I mean, I think that there's a lot of literature to support, but it's maximal strength nonetheless. And there's other characteristics of muscle function that maybe would help us to improve the prognostic utility of dynamometers that we should consider, and also maybe updates for technologies so we don't have to look at a needle gauge and then hand enter it into a computer, for example, our hand grip strength. So maybe utilizing some of these technologies such as accelerometers. So maybe if an individual is squeezing a hand grip dynamometer, an accelerometer will maybe help to measure muscle contraction induced tremoring. Maybe with a digital dynamometer such that we can observe grip force in real time. Over time, we have opportunities to maybe examine fatigue or resilience as it pertains to fatigue, or rate of force development such as explosive power, which is strongly predictive of falls, and maybe just like bilateral coordination overall. Also, maybe squeezing a dynamometer on both hands at the same time would maybe help to exhaust some of those neural characteristics that we kind of mentioned are really important for geriatric assessment as a whole. So there's a lot of opportunities for improvement, how we operationalize muscle function with hand grip dynamometers in clinical settings, and how we can, I think, improve the predictive utility. So we can't just say to our patients, oh, well, you might be considered weak, for example, but we don't necessarily know what you might be at risk for. So maybe evaluating these other characteristics might help to specify that risk.